Hello, it is Matthew Holt. It is yet another episode of THCB Gang. And who do we have to tell you all about the world of health and technology, especially technology, this week? We have a special lineup. It's a bit of a special show, um, suggested slash demanded by my friend Jen Goldsack at the Digital Medicine Society. We have Jen, the CEO of Digital Medicine Society, been on THCB Gang many a time. Nicole Bell, a first-time comer, is the Chief Commercial Officer at Curai, and I have no idea what Curai does, and Nicole will probably tell us. And Nicole Zanetti, has many titles, and one of them is the Chief Health Information Officer at the VA in Charleston, South Carolina. And I suspect you can tell us what the VA does at some point. It's probably doing a lot of stuff we don't know about. So that's who we got, and we have all, I think, just returned from I don't know what you want to call it, the world of craziness that is Las Vegas, where we go and have a very, very healthy 3 or 4 day period where we just stay up all night and drink heavily and gamble and no one does any exercise, and then we call it a health conference. So that, all right. So we're on, we're off, we're live, and we're going. Jen, uh, big week for DiME. You announced a bunch of stuff, and let's start with the biggest of the lot, which is that as I've been joking around about your animal welfare work, DiME created something called the DiME seal.
That's
Um,
right.
so what is it? Why do we need a seal? What is your seal? I assume it's not that mammal that swims around when you're canoeing out in the bay in the Pacific. And what does it do and how does one get one? So give us the background for the seal.
Well, I'll refrain from barking like a seal or putting a red ball on my nose, but let's get into what it actually is for.
Those are sea lions, by the way, in the circus, not seals.
Oh,
I know all
I've got
about
to get, I've got to get, more on top of my Pacific Northwest aquatic life, I suppose. Gonna lose my credentials. So, here's in plain language of the DiME seal is it's essentially consumer reports for digital health software products, sort of very broadly defined from wellness products all the way through to both clinical and administrative tools that you'd find in the hospital. And here's the suite of problems that we're confident that the DiME seal is going to solve for. So first of all, the burden of de-risking a software purchase decision, whether it's for an individual, whether it's for a payer, whether it's for a healthcare system, is intolerably high. And we actually did a listening session a couple of weeks ago with a few hundred CMOs from all 50 states, a variety of different settings. And they were basically telling us they make 20 strategic software purchase decisions a year, like strategic, high level, system wide. And it takes them about 75 to 150 hours to evaluate each product. And of course, there's many of those products that are evaluated, multiply that by the number of system settings, so on and so forth. And that even assumes that you have the capabilities in-house to be making those decisions. And so it's a market failure that it's incredibly difficult to identify and de-risk those purchase decisions, which means that we're either slowing down the pace of innovation or we're making investments that are not going to return to systems or to the patients that they care for. At the same time, there's also the developers who increasingly are building exceptionally high quality, trustworthy products, but are struggling to distinguish those solutions in a very crowded and complicated market. So the goal of the DiME seal is essentially to remove that market failure, to make it easier for end users of digital health software products to identify those options that are likely to sort of meet their needs, at least at a baseline level, before they decide whether they're fit for purpose. And also to make it easier for those developers who really are working hard, doing the right thing, and have a solution that we should all be paying attention to differentiate themselves in the market.
Okay. So this is aimed as a user base at the users of digital health technologies, primarily those in current healthcare systems? Or is it also aimed at users of digital health technologies who may be also digital health companies themselves, but using other types of tools? How far down the line does this go, and what kind of products are going to get that seal for first off?
Yeah, so we aim to make this as inclusive as possible because we wanted a unifying framework as opposed to here's an edge case over here, here's a different set of criteria over there. That one makes the market much more complicated, and two, it actually doesn't lead to global best practice when it comes to these sorts of things. So it is absolutely healthcare systems thinking about making decisions. It is absolutely sort of large payers who are thinking about what do we want to put into our sort of chronic disease management platforms, what do we want to put into our own administrative platforms, what do we want to put into our wellness programs. It's also for patient end users. And Matthew, you're absolutely right. Anyone who is also consuming other digital health software products as part of their own tech stack, only then to go on and deliver a very holistic service, it is absolutely valuable for them too. The other constituent on the end user side is investors, right? I think one of the most interesting use cases, and sitting alongside Cole, who also sits on our governance committee for the DiME seal, are Annie Collins, A16Z, Daryl Toe, General Catalyst. And one of the things that they've reminded us of, especially for earlier stage products, it's much, they want to be able to identify those developers who are actually really on the right track with their product development roadmap, and this will help them do that.
Okay, so let's drag in Cole and Nicole here first as to why they. So if I were to be understanding and thinking deeply about why it is too long, you've got a user and a developer with you, right?
I mean,
did I figure that out all by myself?
We should, we'll start, calling you Poirot.
All right. But I do have a question for everybody, all three of you here, right? Which is that this isn't the first time someone said, let's help it make it easier for these two, right? You have people like Avia, who've got a massive database of these things, and a lot of health plans, I don't know if the liaison mental health investors apart. There are a couple of commercial efforts to try and sort of identify the world of health technology and sort of to give user views. I know Daniel Kraft is doing screen around with digital health, and the folks at Elion have been doing something. And if you go back to when Health 2 Pro was starting this, there were a whole bunch of people who were building accelerators and then doing pilot programs and trying to measure and rank and rate them and all that kind of stuff. So there's been a ton of information out there about who's been doing what. It has not, I would grant you, been easy to find. There has never been an official good housekeeping seal of approval. People talk to us about this from the consumer end and from the user end, wide organization end forever, but it's never been easy. But it's not like a brand new idea. So why you? Why now?
I can start there, and then I'm really curious to hear both from Cole and Nicole about sort of their motivation.
You're sucking them into joining in this. They had a reason.
I know.
Presumably could have done something else. Not only with their Thursday afternoon, but with their time that they have to do their job. So
I know, exactly. It's funny how this group came together. So, and it's also funny that you mentioned digital.health and Avia. So we're actually looking to augment what they're already offering. So digital.health has already embedded the DiME seal into their search functionality. So if you are looking for a third-party evaluation of the digital health software products that they have in their marketplace, we're connecting the two systems. So as we award different software products the DiME seal, that will be recognized through digital.health. And we're having ongoing conversations with Avia to do exactly the same. So this is not intended to be sort of competitive with or distracting from, but in fact to say, when it comes to high quality, trustworthy digital health software products, regardless of where you're getting information about purchase decisions or where you're looking for more holistic information that's sort of full stack for your system, you can always rely on the DiME seal to differentiate between those software products that are sort of trustworthy and those that are not. And when we think about timing, and this is something that I am going to kick over to my colleagues, I mean, we've wanted to do this since we established DiME. This has always been on our roadmap for the last 5.5, 6 years at this point. What we wanted to do was, one, establish that we had the credibility and the leadership to be that trusted third party who could actually bring together the community to set the benchmarks together, which is exactly what we spent the last 18 months doing, that people would trust us to be that independent third party, that we have a history of doing evidence-based work. But two, we also had to get to a point where the market itself was so crowded and complicated that this was a real value add, and when the end users were actually really feeling the pain and would be looking to rely on something like this. We rely on third-party certifications in every other area of healthcare, whether we're looking at sort of Magnet for nursing, whether we're looking at NCQA or JCO, whether we're looking at sort of ONC or ASTP ONC certification program for EHR, which somehow or other is still voluntary, right? This is what we rely on for our decision making, and the timing was right to do it for software products.
Okay.
Cole, I don't know.
We'll go back to that lot in a second because I have some questions about certifications and values, but no. But Cole and then Nicole, why don't you weigh in on the sort of why you care and why now question?
Yeah, I mean, I think a lot of people talk about this stuff, right? How, what does it mean to be valuable in this space is colored by the perspective that you're coming from, right? If you're talking a VC-backed element and you're looking at ROI, you're looking at where's the market. If you're looking from a privacy security perspective, you have certain parameters. When you're looking from a patient's perspective, you have immense amount of focus on usability and ease and access to your data. And on the clinical side, it's how do you not make my day hell by dumping stuff on me, and and making sure this actually fits into a clinical process that makes sense, right? And into a medical record system or electronic medical record system that already exists instead of me having to log into 5 or 6 different platforms. So the issue is who pulls all that together so that it is coherent and actually addresses all of these different perspectives in one location instead of just hearing the cries from each side with independent ranking processes that don't function in the other areas in completeness. So that's where I've been really excited about the DiME seal, is that it actually pulls these different voices that are all important in the ecosystem together and gives us a floor of expectations, saying you have to at least meet these criteria to be safe, interoperable, have decent user interfaces, and have been clinically assessed to an extent that's reasonable. And you take that perspective in mind, which is super helpful in and of itself. And you have to realize that there's a lot of people in healthcare that frankly don't know any of this stuff, right? We end up being in these great echo chambers of interested nerds like myself that like to talk about this and deep dive into it for years. But there's a lot of people in leadership roles in healthcare that are the decision makers that don't know any of this stuff, and they need a simple way to go to a validated objective tool and say, this is a library of things that are considered safe to use and have met at least a baseline level without having to go to an extensive education experience and become an expert at all things. So that's kind of where I saw not only the timing, but the value.
Okay. Nicole, and before you go, I'll tell you what I think. Curai, mix of tech, AI, and direct service to patients, I believe, run by the son of the guy who said that 80% of colds are going to be eliminated by 20 years ago, or whatever it was. Right. So tell us a little bit about that, and then why. I'm assuming people knew what the VA was, so I didn't get Cole to introduce them. But
yeah. Happy to step back.
Yeah.
Tell you a little bit about Curai and then why we're excited about the DiME seal. And Cole just gave me like 3 more reasons that I hadn't thought of. Sometimes we assume that people that are procuring solutions like ours do know what they're talking about. So noted. So Nicole Bell, I lead the commercialization efforts for Curai Health. I joined the team about 3 years ago. We're a chat first virtual care company. We did start with a direct to consumer product in 2019. And now we are B2B. So we work with primarily payers and providers. We can show up as a white label extender of their clinically integrated networks or of their provider networks. We have been at it doing longitudinal primary care as well as urgent care for a while. We fully employ our physician workforce, so we don't have the problem of moonlighting doctors where you can't ever pick your own PCP or never see the same person twice. In fact, that's what's most exciting for me, is that we can handle longitudinal care needs and we can take care of complex patients. That being said, the reason we go to market with partners is because telemedicine can do a lot, but it can't do everything. You have to have a brick and mortar backstop. The company does have investors in General Catalyst, Morningside Capital, and Khosla Ventures. And our CEO, my boss, is Neil Khosla, Vinod's son. So hopefully I wrapped all of that up, but would take all your questions.
But just before you start,
Yeah.
you're going to the seal, but you're both, right? You're a tech company that does stuff with and builds your own tech and goes into other places. But you also, I don't know how much in the stack is other people's, but you're also a provider. So
Yeah,
I don't know which side of this you're. So try to pull both sides together for the seal part.
Yeah, we would say we're a provider. So we use our own purpose-built tech, and our clinic that we operate uses that technology that we built.
So when you're involved, now talking about the seal, are you
Yep.
are you looking for other people to have the seal, or are you adopting the seal yourself?
We are one of the inaugural seal recipients.
Okay.
And we raised our hand to get this designation, and we're really excited about it. I mean, I go back to, there are lots of conveners that have been doing matchmaking, some of them really smart matchmaking between the enterprises of healthcare and the new companies in healthcare. In fact, I ran a place, several jobs ago in the Pacific Northwest, called the Cambia Grove, which was meant to bring together entrepreneurs with enterprises in Seattle, right? Like a Rock Health, and very familiar with Health 2.0 and all of those models, right? Some of it went away in COVID, but in terms of matchmaking, like Avia does, or consulting or advising, we forgot to talk about EHIR, PHIR.
There's a bunch, right? A lot of accelerators do this as well.
Yeah.
A lot of providers have their own accelerators and see that.
So we need all that. My opinion is we need all of that. We need these legs up, and some of them are good and some of them are not good. Some of them have value.
Need is a strong word.
Okay. Some of them have need to be open and need to try out and see what works for you and what doesn't work for you. How about that? And I think I'm excited for the DiME seal, because where I saw that DiME was stepping in, and Jen and her team, they were more looking in the procurement space. So a lot of young companies can't possibly get through an enterprise procurement cycle, right? You don't have enough cash in the bank. If you're working with a blue plan, well, what blue plan have you worked with before? And the answer has to be, I've worked with a blue plan in order to work with a blue plan, right? So they're caught in that conundrum. And so for a company like ours, who maybe can't hit the traditional procurement with flying colors, but has every bit of traction to be trustworthy and a really good and beneficial service on that roadmap, the DiME seal kind of steps into that space to say, hey, Blue Plan, maybe they can't hit all your procurement stuff, but by the way, since they have the DiME seal, you don't even have to look at these 17 things. And please pay attention to these other interim valid steps that are really useful to you and could help you be considered. So I liked that. Our company has to go through the procurement and the compliance. We also use a lot of generative AI tools in our provider workflow and our customer workflow. So there's going to be another set of compliance and rulemaking and evaluation of the AI products. And so can we get to market with all this hullabaloo? Or do we need some way to step in and just say, look, like we've done a lot here. We are listening to what's important to you. And so, Jen, it hasn't happened yet, but you just launched. So our marketing team is trying to get the DiME seal on our website right next to our high trust and our SOC 2 and our HIPAA stuff. So that's how we see it.
Okay. So that Jen, you've got a process here, right? So can you describe a little bit the process, and maybe Nicole has described the process, to qualify. A, and then B, I'm not having a quick look at who's on here. I don't see a direct competitor to Curai on here. Maybe I'm just not paying attention. But you've got people very diverse, right? You've got Valedic who do sort of back-end integration stuff with tools. You've got SimpliFed, which does, which does God, I'm getting old. I want to say breastfeeding. There's a better word for it. Lactation consulting, right? You've got a bunch of other people doing various flavors. But so how did you pull the first group together? What do you have to do to get in? And then the bigger question is going to be what happens when it gets bigger. So let's do the first part, and we'll do the second part later.
So a couple of different things to find the initial group, and bear in mind that we only launched this week, so the group is small but mighty. But
tell me you've been working on it before this week. you didn't like get drunk on Tuesday night and say, "Hey, let's have a group."
That's exactly right. So a couple of different things. So we went to our community first, right, to provide that opportunity to get in there first. And it's not like we're precluding anyone else. But when we sort of said, look, we're about to launch this, come join us, go through the process, that invitation went out sort of initially to our community. And when we think about the market, we really are thinking about all digital health software products. So we are thinking about everything from a patient-facing wellness tool, right, which could be something like a period tracker, or something like I want to track my potassium and sodium because, I'm concerned about my diet, or whatever that looks like. Regardless of what the claim that product is making, we still want to have evidence, even if it's a wellness tool, right? Show us where you're getting that data for your potassium and sodium levels, right? Tell us how you are drawing a conclusion that you are correctly tracking, a woman's sort of menstrual cycle. We want to see that. Then, we can go through patient-facing products that might look more like a digital therapeutic, for example, or even a remote diagnostic, right? Very high level of clinical evidence required. But then we move through those tools that sit at the intersection of a patient and a provider, then all the way through into what you might embed into clinical practice, whether that's an administrative tool or whether that's something like a clinical decision support system. And that was our hypothesis going into this, that we could absolutely come up with a unifying framework, that we could say that when it comes to evidence to support your claim, whatever that claim is, and we're fit for purpose based on the claim, whatever we're thinking in terms of privacy and security, whatever we're thinking in terms of usability and accessibility, with equity woven all the way throughout that there should be a common baseline that if you can't make that, what are you even doing in this industry? And a couple of the anecdotes that I will share, Matthew, and you're sort of, looking at sort of a week or so in and who's already come through the process, I think two things the team has done very well. First of all, we are not listing those organizations who are not making the seal. We are not, here to be kingmakers. We are not here to select who gets the opportunity. It is open to anyone who wants to come to the system and report their performance. The reason that I say that, the reporting out of a failure to make the grade is not part of our system is because actually we've got about 20 products in the process right now where our team has gone back to them and said, look, you didn't quite make this bar. And of those 20, 17 are actually revamping what they're doing in their process. So some examples of that are some aren't making 8th grade reading level, right? And so they're actually going back and saying, we need to, in the name of accessibility and equity of our products, we need to make sure that anything that's patient facing has an 8th grade reading level, and they are actually reworking text and language within their product. We've had some that don't have the appropriate security controls, and they are going back and making changes. This is the kind of thing that we actually get really excited about. And we've had sort of folks saying, this is disappointing that we didn't make it through, but we need to apply this to our entire portfolio. It's going to make us better. So the ethos here is not that it's a sort of gotcha sort of stamp, but rather it is a way that we can actually say, this is what trust requires, and this is what quality looks like. in a digitally enabled healthcare environment.
Okay, can you just go down the line of what the big buckets are for the requirements, and then compare and contrast with a couple of other people who are in this space who've been talking a lot about, I would say, evaluation of clinical performance. I'm thinking of Peterson and Validation Institute in particular. How far do you get down there, and how much is it like? Do you have the appropriate switch on for whatever weird security compliance thing most people never heard of?
Yeah, so let's start with what do you need in order to get the DiME seal. So there's sort of 3 buckets, which is the first is evidence to support your claim. And what we do is we sort of bifurcate products into, are you making a clinical or a medical claim, or do you have a functional claim? And so those bars are slightly different, but we do require evidence nonetheless. I think one of the things that the team has done really well is that if, for example, you have a clinical claim and you're 510 cleared, or you've been awarded, a sort of market access through the de novo pathway, you just upload that 510K clearance and you test out of the entire evidence section. So we've worked really hard to make sure it's not burdensome for developers. So that first bucket is evidence. The second one is privacy and security. And that one, again, takes the same approach. First of all, we bifurcate based on whether or not you're collecting PHI. So we don't use the highest standard as a stick to beat developers with if they're never collecting PHI. And at the same time, if you have SOC 1, 2, if you have high trust, you simply upload that certification and you test out, you move immediately on. And then the last piece is around usability. So that looks at things like accessibility of the product, alignment with ISO standards. If you're intended to be embedded into a clinical workflow, do you actually dock into an EHR? Those sorts of questions. And then at every single step, we're thinking about equity at the same time. So equity does not exist as a separate pillar. It is absolutely embedded throughout. It's through the sort of reading level of your privacy policy or your terms of service or the app itself. It's, are you meeting sort of ISO accessibility standards for people who might have poor manual dexterity or poor vision, for example? It's when we're looking at your evidence, we want to know if you've done this with a representative sample. So that's the way we're looking at this. And so the way that we distinguish ourselves from existing certifications when it comes to more narrow certifications, for example, something that's focused exclusively on security, is we take the time to recognize that we're not competing with it. We've already done that. That's great. But, not every early stage company has 400 person hours and $200,000 to go and sort of get SOC 1, 2 certified straight out of the gates. The other piece is as it relates to
And can I stop you there a second? So
Yeah.
if you haven't done that, haven't got that, is there a way via this that you can at least show some level of that? Or are you basically saying we're going to tell you who's got that already amongst the group of companies?
So then we let you prove your performance in other ways. So you go in and you would say, so we're asking for like your hashes, right? For your sort of security protocols. We're asking you to upload your privacy policy so we can review that. We're asking you to upload a certificate of like the Fleisch-Kincaid reading level that you can run really easily and for free on your product. We're actually asking you to show your receipts in other ways so that we can be really confident that you are meeting those baselines, but we are giving you a way to do that does not preclude you from demonstrating.
Okay. I get it. All right. And then the sort of the people who got closer to, does your clinical research and studies show, say what you say, do what you say they do, which is sort of, if you go back to something sort of the Al Lewis world of, which is where the Validation Institute eventually came from, of people who said, oh, we saved 95% of costs on this on this one thing, or that kind of stuff, right? Which is where we ended up with Peterson and others. Is that a world that doesn't sound like that met your criteria too much?
No, and we were pretty intentional about that, because what we don't want to do is end up sort of making a mess by trying to do too much or doing redundant effort, because there's no time for that. So we think about quality and trustworthiness, and you'll never be able to evaluate ROI if you're actually building a tool that doesn't even work in your system. I can tell you right now that your ROI is going to be in the toilet if you have a data breach, right? If you're lying about your claims, there's never going to be any value. So what we think about, and I'm curious for sort of Cole to comment on this as someone who actually thinks an awful lot about purchase decisions for software products. We think a lot about the DiME seal being a really good way for an end user to decide whether they even take the meeting, for example, right? So you might go out into the market and you say, look, I'm interested in, an ambient scribe, right? Like I want that kind of software. And if you go into the market for that right now, there's probably 50 something options. You don't have time to do that evaluation.
Yeah.
And, you know, so if there's 50 options, but 12 have the DiME seal, that narrows the funnel for you. That says one of these, you know, this isn't going to tell me whether it's fit for purpose. This isn't going to tell you if it's exactly right for my system, but it's not lying about the claims that they make. They're not going to cause a breach at our system, and they are actually going to sort of dock into our clinical workflows, and they're not going to be a terrible experience for my clinical colleagues that I'm trying to protect. Like that's the inefficiency that it takes out of the marketplace. And Cole, I'm curious to hear that sort of from your side, and then Nicole, as you actually go and make these pitches to potential partners, how you fight through all of that.
Yeah, you know, we are constantly bombarded by those that are trying to enter the healthcare area related to digital health, AI, etc. And, you know, in the VA, we're creating those evaluation criteria, and it, you know, has been redundant in the same areas that DiME has worked to alleviate. We were manually cross-checking all of those things for some tech sprints that we launched. And I was one of those manual volunteers that had to do it. And the reason being is this isn't insignificant cross-checks or validations. These are critical for us to even be able to use the solutions. And so having a filter that's trusted for use and for contracting is going to be incredibly helpful. That's number one. But number two, you know, I also want to just call out this aspect of need for workforce development. When we have medical students and residents and trainees who, frankly, were not trained on any of this, except for a few places that made intentional decisions to do so. You know, these schools are not do not have substantial expertise to delineate these things either. So being able to rely on the DiME seal to be able to say, hey, these are things that we could safely procure and train our students and residents on is not a small contribution. It is an absolute critical need in workforce development that we have not addressed. So now that the DiME seal is here, the osteopathic profession in particular made massive promotion investment in making sure that our medical schools across the country, that residencies and fellows are aware of the DiME seal, what it's used for, and to start using it and as an expectation for evaluating solutions before we train people on them.
Yeah, I might ask you to explain the difference between osteopathic and allopathic medicine and the historical background for that, but no, next time. I'm kidding. All right, but there is something I do want to ask you about. I do want to ask you something about the why that happened and what happened to medicine men in the 1870s. But I do want to ask you a related question about the VA in particular, right? So right now,
Sure.
you've got I don't know what the current state of play is, but you've got this rollout of the Cerner system in some parts of the VA and not in others, and presumably some evaluation criteria for that, which leads me to an obvious point, which I don't know if it's so important for you, Nicole, but it's very, and there is a ton of controversy about this, right, which is integration with big underlying EMR platforms, right? So I don't know if that is touched on this, but obviously you've got one giant outside the VA called Epic, which is, you know, got its workshops and marketplaces and whatever they call, and you know, there's lots of controversy about that right at the moment. As we all know, there's some level of integration, you know, that's required for that and for a big hospital system. I don't know where the Cerner marketplace and the VA's relation to it and all that stuff fits at all. I haven't looked at this at all, but I mean, you think, is that part of this as well? Is that going to be part of this? Is that, or you know, it's table stakes that it does this stuff, and then let's figure out if it fits with what we've got. Is that later?
Well, go ahead, Jen.
Yeah, so just from a SEAL perspective, and then Cole, I'm fascinated how you think about it at VA, which is from a SEAL perspective, if you are looking to embed in a clinical workflow, you can't operate through a separate portal. You actually have to be able to
So
embed.
one of the criteria is this is small and far or something that fits in within the workflow.
Exactly.
You're not going to a separate workflow. Okay,
And
well,
so that's why Curai is such a great example.
We're a fire native system. And I mean, we really are. And we were built that way from inception. Like when I say that, sometimes people are like, I mean, really? Like, I mean, really? Yes, I promise. So that's helpful. But yes, I think more than being a fire native system, like people have to access Curai through the enterprise ingress point, not by going out to some other app and downloading it and then, putting in some relational way to the VA or something else.
yeah.
And then of course, if you're asking about the back end, like the data has to be passed on to the physician of record or onto the referring provider. Like that's got to happen. We look at that as table stakes.
Okay, but there clearly could be some DTC options which are used by end consumers, patients, which don't have that, right? And there's a whole world of people out there who don't care about that. So I don't know if that, you mentioned having some of those on board, Jen. We didn't get Cole to answer my last bit of the question though, which was about how you're thinking about sort of wider integration with, the complexities of as you're rolling out new tools or whatever in the VA, the sprints you're doing, the stuff you're building internally and stuff fit with the old Vista world and the new Cerner world and God knows what else. How does this play into that?
Yeah, this is, this was the feedback that was given over and over again when asked about what we want out of the DiME seal is to verify that this interoperability component is critical. So that's why we're so excited about this too, is that it asks those basic questions that unfortunately, and to be clear, across healthcare, you do not have informaticists in every system. You do not have people asking these questions before they contract. And then after the contract is executed, they wonder why they have to have a different password to log into a platform. And this seems so simple, but it is missed more than you might believe. And in the VA, it will not happen. It's over my dead body because we have burnout that's obscene. And, our part of my osteopathic background is this construct of our job is to humanize the experience of care, and technology can actually help with that if done correctly, not detract. Right up to this point, I feel like technology has actually made it worse, and our job is to dig ourselves out of this. And the DiME seal is a great step in the right direction to say, hey, that you need to be able to integrate and not add to the burden, but actually fluidly help in a meaningful way.
Yeah, I'll tell you one old but funny story. So when my second kid was born, they just put in Epic at what was in CPMC, but Sutter in the fancy Sutter Hospital in California. Actually, it wasn't a fancy one; it was the old one that's now a new fancy one. Anyway, so the nurse comes in and we'd had a kid 3 years before. We're actually in the same room, and there'd been no computer. Now she comes in and she's got her Imprivata badge, and she's trying to damn it to log into Epic, and she's just like this stupid thing, just whining and whining. And she says the problem with this, she just turned around and said, and I said, "Oh, that's interesting. What are you using?" She said, "The problem with this place is that we just buy the cheapest crap." And I went, "I don't think you understand how Epic charges." Anyway, so. That's all right. So let's wrap on the series. I want to talk. I know you guys have got class stuff to talk about, but there's 2 things to go right. One is, enforcement or Jen. I assume you believe everyone's going to get through this, and what happens when someone gets through this, and they've got a seal, and then Cole tries to shove them into something, and it's not as advertised. So one is enforcement about these things. How do you? Assuming you catch as many of them as you can up front, but there have been other not validation, other certification bodies who have had to come back to things after time. Hints and big fines in the world of to virtually everybody in the world of high tech. If you go back to, I want to say everyone got busted to some extent. eClinical works had a huge fine, and cheating on you're only a small team. Someone's going to try and get something past you. This is America. What are you going to do?
I think that's the human condition. I'm not sure it's just America, but
it's better here.
So
Less in Finland.
we are absolutely addressing that, and we have to, right? Because the DiME seal means nothing unless we maintain its integrity. So there's a few things. So on the website itself, there's a couple of places where if you see a product listed and you have concerns and you don't believe that it's actually high quality, trustworthy, you flag it. And we have an internal process whereby one of our DiME seal team would actually go back to the developer and actually, I mean, they'd scrutinize the application first, and then they'd go back to the developer and they'd work through it, right? So it's not an immediate assumption of sort of, you know, nefarious behavior, but we'd actually go back and say, did you understand the question? What does this look like? Okay, this isn't the correct documentation. We need to see it, or we're going to remove the seal. So that would be one pathway. And I'll tell you what we do in those cases where we will remove the seal when we go through the pathways. The other thing is, you know, our team is also sort of monitoring media activity around those products that have the seal. So if there's some kind of big blow up and there's a privacy or a sort of security issue, you know, we would look at that also, and that would sort of trigger an internal investigation. There's also substantial updates to the software product itself should actually trigger the developer to come back to us per the terms of service and say, actually, we've made some changes. We need to review X, Y, and Z, and we're going to re-upload. So that would all be sort of part of your 1 year sort of period of having the seal. In those cases where either we find something in the public domain or that we receive sort of a complaint or sort of whistleblower activity, that we would do an investigation. If we do actually end up removing the seal, then we're not going to do a press release or something like that. But on the page where we have our catalog of products with the seal, we will actually list that we removed this product on this date. Here's why. Because just simply taking it away doesn't help someone who may be in the midst of a purchase decision, for example. We actually have to say, you may have checked here last week and feel good about it, but if you're checking here again, then you need to know that we revoked this.
So let me go to the other side, which is, I assume, I mean, you're a very nice person, but you're not doing this all completely for free, I assume. So you're going to have both what does it cost to go through the process now to get the seal? And more importantly, what are you going to do if what you would hope to happen, right, is that people like Cole and a bunch of others go to their current vendors. I don't see the seal on your side yet. I mean, obviously there's evaluation of new stuff, but they're probably in deep with them. They can't get rid of them, but they might want to say, I want to make sure that you are at least hitting these criteria and want to go back to DiME. And there may be some either blowback or grumpiness if someone's already sold something to somebody and they come back and say, go do this. And now I have to pay, you know, DiME an additional tax. So what does it cost? And then what do you think is going to happen when, have you thought about that sort of process of what happens when you have to start backdating, or is that the right word? Going back to people who are already in process because their vendors, because their customers want them to do that.
So a couple of things that I think are interesting, and then I am going to get to the price, and it's not shocking, by the way, because it's non-profit, it's not non-revenue, sadly. Although, you know,
yeah, you're a non-profit, just like Kaiser and Ascension. And
yeah, that's right. That's right.
I know you spend most of your time with your hedge fund, but go on.
In my dreams, I do indeed. So I think here's the thing, and this is also why, like, Nicole did a really good job of saying this is why an earlier stage product really benefits from this in terms of market differentiation. I also think, speaking of KPE, like looking at how quickly they switched, right, to a bridge and how low switching costs are in a software era, even those traditional medical devices that are now starting to offer AI sort of additional services and wrappers, anyone can build those services, right? And so when switching costs increasingly go down, I do think that there's a real reason, particularly for some of the pieces that we have around usability, accessibility, equity, that the DiME seal is going to be really important, even to the incumbents, for exactly the reason that you say. And the price point that we have. So the problem that we're really trying to solve for is the burden of de-risking purchase decisions, because we want high quality software to be powering healthcare. That is how we make it better. Or one of the ways that we are going to sort of make it better, make it sustainable. So we are not placing the cost on the end user. The catalog, the library of products with the DiME seal is absolutely openly available. It's searchable, this, that, and the other. So it's the developer who is paying to be evaluated. It's $17.99 for each evaluation, and that's annual. And the way that we looked at it is, you know, if you're thinking about what it costs to go and get a booth at Health, for example, which we've all just come back from.
$1,800?
Yep.
Way too cheap.
But here's the thing.
I'm always the opinion, if you don't charge Americans a lot of money for something, they don't think it's worthwhile.
But here's if we, the value of the DiME seal, Matthew, comes from when we capture the entire market. from when every single product, and we think there's probably 50,000 or so out there,
and
the
that probably
DiME seal come through. So we need to be able to get to that coverage. And we are silly, and we are doing the end users and the developers a disservice if we make an unnecessarily high bar. We made a lot of investment into a platform that's going to allow us to do this at scale. Although early on, we have manual QA on everything, so we can start doing risk-based human QA. But the goal here, I mean, we're a mission-driven organization. It's not to rinse the field. We're not a for-profit organization.
Okay. Right. So we only have 10 minutes left. Do you want to chat about anything else about the seal? Are we beaten the seal to death like we were on the ice floes of Newfoundland? Do they still do that? I don't know. That was always the big thing in my. Brigitte Bardot was always out there stopping the seals being clubbed to death. But
I'm sure I did a primary school project on it.
How about I transition us to health? So I was in the audience when Jen made the announcement, and someone who's a buyer from a health plan was sitting next to me, and she goes, "Oh my gosh, I need this," which is like the bet that Curai is making in joining it, is that folks would get it right away. And so I bore witness to someone getting it right away, and I thought, well, that's why we're doing it as well. So good to sit in the audience anonymously sometime and hear those tidbits, which is maybe the value of health, right? We all go because we all go. So there you go, Matthew.
and I thought it was the free whiskey. So that's great. So let's touch on health. Two real quick. Anything else that you saw at health you thought was interesting? And I have a couple of tidbits that I can spiel, but I'll do that later. But the other thing that I did run into health, I ran into John Halamka with a very nice young Englishwoman who is now new chief of staff for Chai, and the guy whose name I don't know, but you do know, Jen, who's running Chai on the admin side. And John Halamka's
Lucy Orr and Brian Anderson.
Thank you. I don't know. Don't ask me who the hell I met. I'm old. I can forget stuff. I used to know stuff, but now it just goes out. So Lucy, I hadn't met Lucy and Brian before. I'd obviously known John many years, and we stopped and he asked about that. And they had just come out of the Chai meeting. Are you still in that?
Yep. So I'm still sitting on the board.
Right. So Chai, for those of us who think it's a weird Indian sweet drink they sell you on trains, is called the Community for Health AI. Is that correct? Did I get it right?
Coalition for Health AI.
Oh, that should have. It's was at one point had some government people involved. They've all left for reasons I don't quite understand. But anyway, but what is Chai trying to do, given the role of AI in a lot of things, including in Nicole's product and all the stuff Nicole's starting to use and the stuff that is now being foisted out to the general public and also to every doctor in America, as you just mentioned, Abridge and Nabla and all the stuff that's going on there, in terms of the world of ambient AI has been, the biggest growth area we've seen probably in health tech for a long time. What's Chai up to?
I mean, they're making tremendous progress. So they are driving towards a network of assurance labs that are going to be able to evaluate based on data sort of housed by or accessible to the labs, the performance of sort of models underpinning health AI applications. And so that is intended to be a service for those organizations that may not be able to do those sort of evaluations in their own systems and are looking for sort of a scorecard or a report card that will tell them about model performance. And it's specifically looking at sort of claims the model is making. It's looking at things like equity. It's looking at sort of where the data comes from, the integrity of all of that. And that is moving along really nicely. So health, they publicly sort of revealed the model card, so the evaluation framework that the assurance labs will go on to deploy. That's now open for comment, and it's open for comment from everyone, from patients and patient groups through to sort of highly technical sort of computer scientists and every sort of healthcare system and clinical experts in between. After the comment period, that will be resolved, and then Brian's leading a really tremendous effort to get to a point where the first implementation lab is ideally sort of selected and moving towards implementation by the end of the year.
Okay. I went to a conference 2 weeks before health up in Seattle, which had a guy called Harsha Nori, who was the sort of smartest young guy I've ever met, I think, who's at Microsoft's lab and does a lot of their work with OpenAI, where he did explain, exactly how the whole thing worked in a way that I understood for a brief period of time. I've forgotten now, of course, it leaked out of my ear. But he did say in the middle of that, really, they didn't know how it exactly worked. It was impossible to know. So you're trying to do evaluation and care and whatever and all the rest of it because that. All right. Very, very good. Looks like we're losing Cole. Cole, thank you. Thanks for coming.
Thanks, everybody.
We will look for it. I guess it's late in the night where you are, and they're probably shutting it. Yeah, it's the VA government organization. I'm surprised it's still open this late in the day. All right, fantastic. All right, real quick. Yeah, I've got a minute left. What else did you see at Health that impressed you that you liked? What else? Just give me a Nicole. Give me a quick 1 minute of your favorite moments.
I've got to say, did you hear of or go by the Photon booth?
Oh, Photon Party, does that count?
So they rebuilt a Blockbuster Video to make a corollary between all of our archaic things that we do and, how they're building to the future, right, of digital prescribing by clinics. Yeah. But it was very creative and very lo-fi. Which was just a big distinction on the floor and quite creative. So that was good fun because there's always a who's got the worst booth and who's got the best booth competition. So I think that was really great. And I guess last year before going to Health, if you typed in their little agenda for topics that you wanted to look for and you typed in AI, exactly 0 sessions would fall off from your criteria search. This year, there were some agenda topics that were not AI focused. So I found that to be a big plus. And
I ran one of those and one of the people insisted on bringing AI into it.
Well, okay, bravo for trying. And I would say, so that was a positive. And I would say on the we need a correction moment is that a number of things that I saw, just the patient never came up. The patient just never came up. I was on an I was in a 5-person oncology talk, and the word patient was used twice in an hour. And it was just about the governance and the new tools and how are we going to oversee them and how we're going to this and that. And I'm thinking, how many oncology patients are dying because you're not going to figure this out or make use of these tools timely or the advances that we have. And so I'm just thinking about how we can get back to putting the patient, member, consumer back to the center of things and not let that get lost. And how do we hold
never were in oncology?
Oh, well, okay. I have been in primary care world for a long time, so that tends to be a world that's all about the patient.
There's a Trumpian "Make America Great Again" time when primary care was like that, but that wasn't ever true either. I mean, I'll tell you one. Actually, the most amazing story I heard was I was on a live the Health Tech Talk Show. I'm probably know Kat McDavid and DeBurry, and for some reason Kristen Valdez from Be Well Connect came on, and then I had to leave to go do they made me do a panel on aging, and I felt discriminated against because I went, hang on, they looked at me and he's old. Yes, we better have him on do the aging panel. I did say to them, I went to see Health earlier and sort of
wait a minute, aging's universal.
No, this is about old people aging, not young people like you two. This is about people getting on, although they crammed all kinds
have a nice dialogue about menopause next. How about that?
They crammed AI in the labor force, long-term care. They shoved some poor Brooke Quinn from Carrot Facility on the panel to talk about menopause, which I think is pushing aging a bit, but anyway, whatever you depends. So now we're going from like 45 to 90, but anyway, I had to run away for that. After I left, I actually went back to listen to see what she said on that talk show. Kristen told this amazing story about herself and her daughter. Her daughter has a very rare chronic disease. Is in the hospital was in the hospital at Johns Hopkins. They ran an entire genomic panel and blah, 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 found out that there's one drug on the market that might actually do her some good. And then she had to get, I mean, everyone should go listen to this story. She had to get, authorization from whichever health plan it was. And she used to be in the United Healthcare executive. So we'll see how she does. Anyway, the upshot is went through all the regular channels, couldn't get it. They kept on going back saying, this is, experimental, illegal stuff. They're going to kill your daughter. And eventually she managed to, back channel away to the CEO or whatever it was, and showed him the sort of spreadsheet of, here's how much time my daughter's going to spend in hospital. It's like 50 grand for the drug. Here's how much time she's going to spend in the hospital the next year and a half, but while she dies, if this doesn't work, right? And it's going to be 6 admissions to John Hopkins at about 30 grand each. I will show you the cost benefit analysis as to why you should do this. And she also at one point put 40 grand down on her credit card, which is a non-trivial thing, right? So this incredible story she told about this. Anyway, the end of the story, her point, I hate to steal her line, but her punchline, but it's so good, is that the day it all worked, right? Daughter got the care, discharged, all fantastic. But finally, because back channel it, they called and said, oh, well, perhaps we can have another review of this. And, the CEO said, you better sort this out because it'll end up on the Health Tech Talk Show. And as it did, right? At least she didn't name names for who it was. And the doctor came in with 5 other doctors. And she thought, well, that's a bit unusual, whatever, was taking to discharge her daughter. And they said, each of these doctors has also got a patient who needs the same thing. Can you do it for them too? So she set herself up as patient advocate. I thought that's a pretty remarkable story of, like to say, very dedicated patient advocate who also runs a health tech company on the side. But they're not on your list yet, Jane, but they'll get there.
We are doing some very, very cool work that we're going to be announcing in like a month or so.
All right.
On hospital at home. And they're really bringing a lot of this into the home as well, which when you come to sort of, I think cost benefit is going to be amazing.
All right, Jen. Oh, we didn't let you. What's your favorite? What was your favorite spiel? What was your favorite your moment from health? Yes.
Yeah. So echoing what Nicole said, it wasn't the sort of like AI sort of frenzy, but what I really liked is that it was much more holistically focused on how do we actually improve care, right? And AI was part of the stack, but it's part of the story. And I think that's where it appropriately belongs. And I also did think that the atmosphere, that I think the discussions, that I think the case examples that were being universally discussed, it was more positive than last year. And so it felt sort of positive, but also pragmatic, right? How do we actually get this done? What are the payment models to get this done? How do we think about tech as an enabler to be able to extend this, make it more accessible, make it more equitable, make it more sustainable? It felt like a substantially different conversation to the last few years where we had sort of the hype and hyperbole. It was pretty, demure. I actually think that's probably not the right word for health.
It's word demure. That's exactly how I think.
Last year it was definitely very guarded. There were a lot of people who were really struggling, perhaps didn't see a way forward, and it felt like we'd sort of right-sized everything this year. And it was like hard conversations, great case examples, true leaders doing good stuff, and a general sort of drive in the right direction. And so I came away feeling really good, actually. There's still a lot of work to be done, but I think we're asking the right questions, and we have really integrated, thoughtful, intentional solutions, not a lot of crap.
If I was to add my comment, I think if I would slice off mental health, I think, and Nicole, you're an example of this, right? I think I did an interview which I haven't shown yet with Lyle Berkowitz, who is what I don't know if you know his company, which is Keycare, which I call dinosaur preservation. Can we try and help those old useless incumbents do after hours care and do population health? But he was like, but also can they keep their patients so they can shove them to the bottom of their organizations that make money, like the cardiac cath lab and the neurosurgery suite and all the rest of it. It's pretty blatant. I think with the exception of mental health, everyone else is done. I don't think there is there are a few people I know, she's trying. There's a few people trying in different categories to do, virtual first care that is unconnected to health systems, but you just look at the firepower on one side and what's happened on, for those companies on the other side. You look at what's happening in the public market. It's a brutal, I think the way for digital health to make it, and all the stuff we talked about to make it to people, is sad. Like it or lump it, it's through the incumbents that we got. big plans, the big providers, and I'm depressed about that as a general thing, but I think that's where we are in general. I take mental health aside. I think there is some independent mental health stuff because there wasn't really a great place to go for mental health before. So I think that's now the case, and the conversation is getting more sensible about that. I still, for the poor venture guys, I don't see a great way out. I still see a bunch of people being invested at, investing at alleged numbers that don't make sense given what those competitor companies are worth in the public markets. And for your CEO's dad, rather than Nicole, I don't know how we get to where those people who had all that money put in over the last 5 years get it back, and that to me is something that may work itself out, but is a long, painful iteration. I think that was some evidence of that at Health as well. But that to me is where the conversation is. The good news, and maybe it was random, and maybe it's because I have the massive celebrity crush on Halle Berry, is that I heard a hell of a lot about women's health, and menopause, and stuff across the board, which maybe I wasn't paying attention before. But I ran, I was part of their Digital Health Awards, had a great women's health section. There was a lot of it in the random panel I ran on aging. Halle Berry had a long thing where she advertised all her problems and her solutions, and it was a big ad for her, and a big one with Lance Bass advertising Dexcom. I didn't see the Lenny Kravitz one. I don't know he was advertising, but it was a lot of advertising. But it was advertising something that's very necessary that hasn't got talked about for many years. And I think that to me was a big. Maybe I wasn't paying attention before, but I think that's new. So you two are women, you may have noticed that. I don't know.
Well, and it's back to patient-centered, right? The Halle Berry conversation was very patient-centered, right? I mean, so I really enjoyed that. I watched that one too.
I left feeling so inspired by that too. And then on my way home, read a new sort of bit of investigative journalism from The Guardian that sort of interrogated this boom in women's health investment. And then they actually broke it down. And the investment dollars that women's health companies with a female founder are getting are so substantially lower than women's health companies founded by men. And what's really interesting, so that came out and just absolutely made my blood boil.
But that's been the case for a while. That's been known for a while.
Yeah.
When it
comes to women's health in particular, the actual, the sort of the actual experts, and we were talking about sort of patients being dismissed. And then funnily enough, RH actually this week also announced their investments or their sort of recipients of enormous amounts of funding to advance sort of women's health, which I think about 60% of which is women's health tech. Now they skew in the right direction, but PIs on that are about 60% women, 40% men. And so we just, in some ways, I'm seeing great progress. In other ways, we can't get out of our own way. And until we have innovators, investors and clinicians who actually represent the patients that we're all here to serve, we're going to continue having these problems. And it was Matthew, I felt really excited like you did. And, Nicole as well, sort of talking about how patient-centric, like the Halle Berry conversation was. And I left Health feeling really good about that. And then I read this bloody Guardian article and it's like, talk about back to earth with a bump.
So it took one day for the cynicism to return. Well, then kudos to you. You had a lot of wannels, right? Instead of manels, they were wannels.
We absolutely did. Yeah.
That's kind of interesting, right? As a conference organizer, so if I go from, and now we're rolling over, so I'll have to wrap this soon, but that's okay. If Joe Rogan can go on for 4 hours, whatever. So Rock Health actually used to do a study of the preponderance of how many presenters there were who were men and women. I think if they were right, they stripped out moderators because people like me used to cheat. I used to only want health tech CEOs, and it was freaking hard, right? I did everything I could. I had a 3 CEOs session once that was all women. I did whatever. I did all the things I could to and I had a female co-founder, Indu Sabaya, to get. Although she always said this doesn't matter. If women are good, they'll make it. She's like the least promotional of the women. She said, you just have to be good, and didn't worry me. I got to be the CEO. What's wrong with you lot? But it was hard. Really, really hard to get tech, to find tech founder CEOs in health tech this is from 2006 onwards. And obviously there are fewer of them, number one. Obviously the ones who are there were struggling, and I work with a lot of them struggling to get the funding. And yes, there's a lot of discrimination, right? Going on within the VC world, and that really struggled. And I noticed that Rock Health actually started then having their own conference. They would have every panel was basically 50-50 at that point in the mid 2010s, which was great, right? Because they said that. But I think, yeah, I mean, I'm now at the point where men have been dominating the world for so long. We should be, put back in the farm or wherever the whole back to the cave or where we were sent from, and just let women run it, which is hopefully will be confirmed in week and a half.
And but hope. I do think the representation was really good among those of us working in the field. I really want to emphasize the important point that Nicole made earlier about I would love to, so the next sort of frontier, I think, is having more patients in the discussion as well.
Yeah.
Well, and actually, if we're going to beat up on health
really
for 1 second, they've been very poor about that. Health 2.0 had a health data palooza going all the way back to when Josh Simon ran the Emission Therapy Conference. They all had patients front and center, and I've seen a lot of it, and patients weren't allowed in for free, like genuine sort of patients this time, which I thought was, I fought this damn war with HIMSS when they bought Health 2.0. I said, you've got to have a patients program in it, but it's and HIMSS has got one now, but it's all these damn things are massive fights. Now, you're organizing a conference, you have 50, I promise you, I mean, I've done this a lot. You have up 50 million things going on, you never enough time, you have a very hard due date, you never enough money. Actually, health has enough money, but so I get why these things get left off. But you're right. It's right now the patients who were there were it helps to be Halle Berry. Not every important patient is Halle Berry. So there we go.
I didn't see it, but they did have a talk to a patient booth, and I did hear that the line was long and it never stopped being long.
And they have that
the need.
Right, they run that with Jen. What's her name?
Hi, and Jeff.
Thank you.
Yeah,
and Sabby Co-op, right? And she's been obviously a big part of this for a long time, so that's great they did that. It's like getting patients into not just patients there
on the panel,
on display. They get patients and letting them come to the conference and doing their stuff, and maybe they are doing it, but I heard from at least one patient that she had to pay money, which I didn't think was great, because patients typically are not being paid by someone to go. Anyway, all right, we have to wrap this because we now gone on a while, and you guys have got the rest of your day to do. And Nicole's on the West Coast, so she probably has to work. Jen, keeping Jen from the Thursday night cocktail, but right. But we are. You have been watching, listening to. Little computer. Jen Goldsack, the CEO of the Digital Medicine Society. I can't speak. It's been too long a week. Nicole Bell, the Chief Commercial Officer. So you call it Curai. Sorry, Curai. I've been calling it Curai my whole life. There is no decimal point in your name. I just screwed that up.
No decimal point. It's just Curai. But look, it's not your fault. I mean,
I'd assume that Neil had just got his Twitter handle wrong all these years. And we also had for a long period, but not anymore, Cole Zanetti, the Chief Health Information Officer at the VA in Charleston. Want to thank the two of you and Cole in his absentia for taking time to come on THCB Gang. I am back, I believe, next Thursday with a more regular gang of people rather than a sort of special one. But it was great to really dive into this idea. Jen, thanks for suggesting it. I think it's really important that we talk about this whole idea about, how do we change the flavor and get people to understand that, the products and services that you can buy, are legit and really help, as we said, those big incumbents particularly figure out, what they should be doing and how they should be doing it right. THCB Gang will be back in next week. Look forward to seeing you all there.